Good afternoon, everyone. Thanks very much for joining the Context for Healthcare webinar on the 2021 procedure code changes. This is John Danza. I'm Vice President of Product Strategy here at Context, and I'll be leading it off and then turning it over to Dr. Steve Nesnidal, our Medical Director here. We are recording the presentation, just wanted to let you know. We will be posting it onto our website at some time in the near future for those who want to re-review it. So with that, I also want to let you know that we're going to handle questions near the end of the presentation. So if you have questions along the way, there is a questions box in your GoToWebinar panel. Go ahead and type your questions in, and we'll handle them at the end. So with that, we're going to go ahead and get started. A little bit about context. We are headquartered in Naperville. We've been around since 1988, and in all that time, we have specialized in delivering compliance solutions. We're heavily involved in payment integrity, fraud, waste, and abuse detection, reference-based pricing. We're a nationally recognized source for UCR fee schedules. Also, we are a healthcare, we license healthcare master data, including CPT codes, et cetera. We have literally hundreds, maybe thousands of customers when you add them all up across the spectrum of health plans, third-party administrators. We have provider groups and life care planners. A variety of people are our customers. So Dr. Steve is our medical director here. He also leads the medical content and compliance department here at Context. He's got a great body of experience, both as a clinician and also involved in medical billing. So we're really lucky to have him. Lastly, before I turn it over to Dr. Steve, I want to note something. You'll be hearing CPT all along the way here. Wanted to acknowledge that CPT is the registered trademark of the AMA. Context is a licensed agent for the AMA. We have been for several decades. We literally have hundreds of customers that license CPT codes from us, and so that's been a great relationship. So with that, I'm going to turn this over to Dr. Steve, who's going to take you through the material.
Thanks, John, for the introduction. Hi, I'm Steve Nesnidal, Medical Director of Context for Healthcare. To get started, in the first two slides, I outline the 2021 procedure code changes I will cover, and due to time restraints, those I will not. I will discuss new 2021 CPT Category 1 codes, and I will briefly present 2021 Category 1 deletions. I will not discuss Category 2, 3, or PLA code changes, so I won't mention changes of codes ending in U, T, or F. Nor will I discuss mid-year 2020 CPT additions, with the exception of a few COVID-19 related codes that were added on or after mid-October 2020. There were many 2021 CPT revisions. I will mention 4 revision themes as well as some revisions that impact new codes, but I will not discuss most revision details. HCPCS codes are released quarterly for drugs and biologicals and biannually for DME. I will show all the new Q1 HCPCS codes and their descriptions, but I will only go into detail on the half dozen or so that we have some info about and that by description are likely to be significant. For the most part, only these HCPCS codes and their descriptions are known. I will not discuss 2020 Q4 HCPCS, with the exception of a few COVID-19 based HCPCS codes added on November 2020. I will not discuss revised or deleted HCPCS codes. We don't know yet how payer policies will adjust to some of these new codes. This is especially the case with CMS and new HCPCS codes. As of note, I will mention some potential FWA and general edit themes as I go through these changes. Before I present our first new CPT code, I'll first outline the 2021 revisions that take place in the Office Outpatient EM Code Series, 99202 through 99215. This slide shows side by side the new revised 2021 code description for 99215 on the left and the 2020 description on the right. This illustrates the significant revision elements. We see in yellow that history and exam were previously key components, and they were previously required to be comprehensive in nature for this code. But after the 2021 revision, although they remain required, they're no longer key components. In 2021, the detail of the history and physical is no longer defined. Only will a medically appropriate history and physical now be required. And the level of detail of history and physical exam will no longer factor into code selection. We also see in italics at the bottom a transition in terms of time here, away from the 2020 phrase, typically 40 minutes are spent face-to-face, and towards the definitive 2021 phrase, 40 to 54 minutes of total time. Time was not in 2020 a basis of code selection of this group, but it is for 2021. So 3 major points that have changed in the Office Outpatient E&M CPT Code section 99202 through 99215 for 2021. Number 1, coding for office outpatient visits will be based on either medical decision-making or total time. Number 2, a medically appropriate history and/or exam is considered part of these services, but does not factor into the coder's level selection. And number 3, when time is the basis of code selection, the total time interval defined in the new code descriptors is used. Added for 2021 are 2 new E&M codes. The first here is 99417. In 2021, you can build a prolonged service code in 15 minutes increments only when time is the basis of your code selection, and only with parent codes 99205 or 99215, the highest level office outpatient visit, either new or established patient respectively. Example, primary procedure 99215. And this code's assigned time interval from its updated 2021 description, which I just showed you, is 40 to 54 minutes. Time beyond this code's usual service occurs at minute 55, which is 15 minutes beyond the minimum time of this code, 40 minutes. So when providers spent 55 to 69 minutes on that established patient per new CPT guidelines, you would bill 99215 plus 1 unit, 99417. And for 70 to 84 minutes, that would support 99215 plus 2 units of 99417. Note that in order to use this prolonged services code with a level 5 office outpatient E&M, the additional prolonged service time must be on the date of the primary service. For more details on key concepts behind the 2021 changes in this section, I recommend you review the revised medical decision-making table on pages 16 to 17 of the 2021 CPT Professional Edition. You will also find some pertinent changes in the section on time on pages 7 through 8 of this edition. The caption specifically related to office or other outpatient services is on page 8. This slide provides a visual summary of total time as it will apply to office outpatient E&M encounters in 2021, according to CPT guidelines. When a coder is choosing a level based on total time, in order to code a new patient level 5, 99205, by CPT guidelines, at least 60 minutes of total time must be documented in the medical record. And to bill for prolonged services, at least 75 minutes must be documented. And when an audit confirms a commercial record for 1 unit of prolonged service code 99417 reported with an established patient level 5 service, he/she must see at least 55 minutes of total time documented. When we talk about new HCPCS codes later, I will show you that CMS has released their own G-code for reporting prolonged services in this context. Spoiler alert, the time requirements for reporting one time-based prolonged services HCPCS code differs from CPT. Regarding monitoring for potential fraud, waste, and abuse in the office outpatient EM code series, we can examine code frequency here from several angles. First, we can examine the distribution of the given provider's 99205s and 99215s relative to their lower level codes. After 2 decades, several coding parameters here have changed this year. And these may all influence the code level distribution of a given provider or group. Number 1, no 99201. This code has been deleted, which I will discuss a bit later. Number 2, history and physical exam are no longer key components in determining code level. Number 3, either MDM or documented total time can support whichever is optimal for the encounter. And number 4, the definition of medical decision-making has changed for 2021. As always, an E&M code distribution of a given provider in a given time interval should be shaped in some semblance of a bell curve. This may be appropriately skewed towards higher levels for that provider that has higher than average patient acuity or complexity, a high-risk specialty, etc. But still, it should not show exclusively level 5 services. You will see shifts in code distribution between 2020 and 2021 because of these elemental guideline changes. If that provider was and is following coding guidelines, he or she should be able to explain and defend those shifts with their medical record details. In 2021, due to ease of documenting total time, it will likely be the primary method of documentation support for office outpatient code selection. As a result, we at Context will add an FWA report function that will allow the user to monitor the sum of time-based codes reported by a given provider, so the user can identify days when that sum exceeds that provider's typical daily shift time. Aside from monitoring code distribution, also watch out for how often add-on code 99417 accompanies a level 5 office outpatient service, as well as how often add-on code 99417 is billed 3 or more times by a given provider. New add-on code 99439 will work with the established but revised Chronic Care Management Services Primary Procedure Code 99490. First, the description of this add-on code's Primary Procedure Code 99490 has been revised in 2021 to include first 20 minutes of clinical staff time directed by a physician or other qualified healthcare provider per month. In 2020, it previously said at least 20 minutes of clinical staff time. So last year, 1 unit of 99490 was used to report CCMS 20 minutes or more, regardless of excess monthly directed staff time. But in 2021, we can use the parent code for time between 20 to 39 minutes in the month, and we can use this add-on code 99439 once when the monthly time is between 40 and 59 minutes, and in some cases twice when time is 60 minutes or more. With this slide, I just grayed out and reproduced the same 99439 description, but I want to show you attention to the parenthetical notes that are after this code. Regarding inappropriate FWA billing patterns here, our edits will fire after detecting several atypical patterns. These patterns are based on these 3 parenthetical statements listed in 2021 CPT below this new add-on code 99439. Listed red on this slide. The first parenthetical statement directs the coder to complex CCMS codes 99487 and 99489 for those services of 60 minutes or more that require moderate or high complexity medical decision making. So, although 99490 with 2 units of 99439 can be billed within a given month, this should only be the case when time supports this, and also when this involves straightforward or low complexity medical decision making. We at Context will fire a warning edit message when that second unit of 99439 is detected in the same calendar month, directing the user to review the medical record. If MDM is straightforward or low, the second add-on is appropriate, but if not, this is undercoding. Number 2, because of this second statement, do not report 99439 more than twice per calendar month, we will fire a different edit message when 3 or more units of this code, 99439, is detected in a month. Such a service, if not billed in error, should instead be billed with the appropriate complex CCMS code. And number 3, from the third statement, do not report 99439, 99490 in the same calendar month with the series of codes. A third bundling edit message we will fire when it detects in history, in the same month, same patient, same provider, any of these services mentioned in the CPT note, including end-stage renal disease-related monthly services, individual physician monthly supervision and domiciliary rest home, care plan oversight monthly services, etc. Whether you are a provider or a payer of CCMS, it is in your best interest to monitor for these 3 billing patterns. So now I've gone through the E&M code series in the front of the book, and I'm going to then start up with the new surgical codes in the CPT section. There are no new codes in the 10,000 and the 20,000 section, but there are 2 new codes in the surgery respiratory system section. New 2021 code 30468 is for reporting the procedure of installing an implant in the lateral nasal wall to treat nasal valve collapse. It will typically be reported by ENT or plastics or oromaxillofacial surgery specialty providers. So consider screening for these provider specialties as performing provider of this service. 2020 code 32405 is being deleted. The description of that code was biopsy lung or mediastinum percutaneous needle. It's being deleted in favor of this new code, the 2021 CPT Code 32408. 2 significant differences. First, the new code is worded more clearly regarding core needle biopsy. And second, the new code description includes the guidance, after it was found that more than 75% of the time, the surgical portion and the guidance portion of this service were performed by the same provider. The FWA theme here, the medical record documentation of a surgical report supporting 32408 should either clearly mention core was performed in the procedural section, or the yield obtained for pathology should be documented as a core of tissue. Ideally, both the procedure and the results should document this. To bill a needle aspiration, which does not yield a core of tissue, instead yields cells in a suspension, with this new code 32408 is an inappropriate instance of upcoding. Such an aspiration should instead be billed with the appropriate code from the FNA section of CPT, 10004 through 10021. 3 new transcath intracardiac procedure codes, 33741, 45, and 46, are cath lab procedures performed on patients with congenital cardiac anomalies, typically by interventional cardiologists or on infants less than 6 months of age. The first code, 33741, is for a septostomy done to improve atrial flow, and hence TAS in its description. There are 2 2020 codes in the medicine section that are currently being reported for this service, 92992 and 92993, but they will be deleted, and this service will now more appropriately be reported out of this cardiovascular surgery section. Additionally, there are 2 new codes to report transcatheter intracardiac shunt TIS creation for congenital cardiac anomalies, 33745 and 33746. 33745 is used to code the initial intracardiac shunt location treated, and 33746 for each additional discrete intracardiac shunt location treated. The edit theme here: do not report 33745 and 46, along with the congenital heart catheterization codes 93530 through 93533. Next, about these two new cardiac assist codes on the bottom of this slide. Cardiogenic shock is defined as hypotension with evidence of end organ dysfunction. 4 types of percutaneous mechanical circulatory support devices are currently available for managing cardiogenic shock: intra-aortic balloon pump, Impella devices, the tandem heart, and ECMO. These 2 new codes, 33995 and 7, can, as of January, be used to more specifically report the spectrum of different scenarios of insertion and removal of these devices. Insertion. Established codes 33990 and 91 have been revised to work along with this new code 33995, which will allow reporting venous access only into right heart. Removal. Established code 33992 has also been revised to work with this new code 33997, which will be used to report removal of the venous cannula of a percutaneous ventricular assist device only in a session separate from insertion. Two new codes in the genital system section for 2021. In 55880, HIFU is a thermal ablation method for treatment of prostate cancer, performed via a transrectal approach. In 2020, this is reported with HCPCS code C9747. And then the second code at the bottom of the slide, 57465. For 2021, this is a new add-on CPT code for use with primary procedure of colposcopy of cervix, colposcopy with cervical biopsy, or curettage or colonization. In this procedure, a computer overlays additional imaging over the cervix that is derived from the reaction of the epithelium to dynamic spectral imaging. This provides additional information to the treating gynecologist about potential cervical disease. An edit theme for 57465, our series of add-on code edits will fire if one of the allowed primary CPT colposcopy codes, 57420 or 22, 57454 through 56, 57460 through 61, is not billed on the same data service by the same provider as this new add-on code 57465. There are 2 new codes for surgical nasopharyngoscopy when performed with dilatation of the eustachian tube. First, 69705 is unilateral. Second, 69706 bilateral. The edit theme here, as is the case generally with therapeutic scope procedures, is to monitor for inappropriate diagnostic scope billed on the same body site, by the same provider, on the same day as a therapeutic scope. As the parenthetical statement under these new codes in red here supports, our CCI edit rules will flag when one of these diagnostic endoscopy codes, 31231, which is nasal endoscopy diagnostic, or 92511, which is nasopharyngoscopy with endoscope, is billed on the same data service by the same provider as one of these 2 new surgical scope codes, 69705 or 6. There's a new radiology code 71271 for low-dose CT for lung cancer screening. LDCT uses newer technology which shortens scan time and radiation exposure. A complete spiral or ultrafast CT scan can be obtained within 10 to 20 seconds or during one breath hold of the majority of individuals. Starting in January 2021, CPT adds this new code 71271 for reporting an LDCT of the chest for lung cancer screening. We expect several major commercial payers, as well as CMS, will require this CPT when reporting LDCT for lung cancer screening. CMS currently requires HCPCS Code G0297 to report this service. The restricted parameters for a CMS screening LDCT benefit are four. First, patients must be 55 through 77 years of age. Second, they must be asymptomatic, so no signs or symptoms of lung cancer. Third, they must have a tobacco smoking history of at least 30-pack years. And fourth, they must be a current smoker or one who has quit smoking within the last 15 years. To satisfy CMS requirements of a screening LDCT, certain registry data must be submitted to CMS, including technical info about the scanner used and the effective radiation dose. Clinical info about the patient's risk factors as well as any nodules detected on the exam must also be submitted. The first edit theme here is age. Patients billed with this code, but who are outside the allowed age range for payer, will be identified by our 1500 and our UB edits. Of note, although Medicare's age range is 55 to 77 years, many commercial carriers, including Blue Cross Blue Shield, allow this service for patients up to 80 years of age. We are monitoring payer policies for evidence they transition to this new code and away from the HCPCS. At that point, we will activate edits that fire when patient age ranges beyond parameters of the screening benefit based on insurance type. The second edit theme here is one of frequency. LDCT screening is a yearly benefit, in contrast to diagnostic CT chest, which is based on medical necessity and is not restricted to once yearly. Lastly, I'd like to mention that the descriptions of the three established diagnostic CT thorax codes listed in front of CPT here, 71250, 60, and 70, have also been revised for 2021 with the addition of the word diagnostic to separate them from this new 2021 screening CT thorax code 71271. New CPT code 76145 is added for use in reporting the qualified medical physicist's work in performing a patient-specific peak organ dose calculation subsequent to an interventional radiology or interventional cardiology procedure that exceeds the facility's established radiation threshold. The medical physicist verifies that the threshold was exceeded, reviews any available literature related to the anticipated dose response, independently reviews the radiation measurements of the equipment used, and then reviews the procedure with the physician and the imaging staff. We are watching out for more detailed information on this code from the American Association of Physicists in Medicine and the American Society for Radiation Oncology. There are 10 new therapeutic drug assay codes starting in January 2021. This section is organized alphabetically, so 80143, acetaminophen, will now be the first drug in this section. These tests yield quantitative results that are performed to monitor clinical response to a known, prescribed, or over-the-counter med. Acetaminophen and salicylate are well-known antipyretics and anti-inflammatories. Methotrexate is an immunosuppressant. Amiodarone and flecainide are antiarrhythmics. Itraconazole and luflanomide are antifungals. Rufinamide, felbamate, and carbamazepine are anti-seizure medications. This new carbamazepine assay code, 80161, is a test of the liver metabolite, the 1011-epoxide, which is known to be chiefly responsible for the tissue toxicity of carbamazepine. This code will list under established codes 80156 for carbamazepine total and 80157 for carbamazepine free. There are several angles to consider when monitoring for fraud related to these new therapeutic drug assay codes. First, consider monitoring for repeat billing of these codes on the same member. Second, as well, consider monitoring for any excessive frequency of billing on any of these new codes. And although in 2021 there will exist specific therapeutic drug assay codes for the drugs discussed in my last slide, Fraudsters may still try to sneak through excessive billing of these drug assays using the unlisted code 80299, as they know it can be more challenging for payers to monitor and detect fraudulent billing using unlisted codes. There are 16 new codes effective in January in the molecular pathology section of Path and Lab. These are the first 6, which are translocation analysis studies. Chromosomal translocation serves as essential diagnostic markers and therapeutic targets for leukemia, lymphoma, and many types of solid tumors. New code 81168 is a study of a translocation often found in mantle cell lymphoma. There are 3 neurotrophic receptor tyrosine kinases that are associated with some solid organ tumors. New code 81191 is a translocation analysis of NTRK1. 81192 is a study of NTRK2. 81193 studies NTRK3, and 81194 is for reporting translocation studies of all 3 of these NTR kinases. New code 81278, a translocation found in follicular lymphoma, is studied here. This test analyzes the major breakpoint region and minor cluster region breakpoints. These are the next 5 new molecular path codes, which are gene analysis studies. 81279 is a targeted study of the gene for Janus kinase 2. A mutation leads to deregulation of the kinase activity seen in myeloproliferative disorders and atypical chronic myeloid leukemia. The MPL gene provides instructions for making the thrombopoietin receptor protein, which promotes growth and division of cells. This receptor is especially important for the proliferation of megakaryocytes, which produce platelets. New CPT code 81338 is an MPL study of common variants, and new code 81339 is a specific sequence analysis of exon 10. New code 81347 studies mutations in the gene SF3B1. These have been seen in cases of advanced chronic lymphocytic leukemia, myelodysplastic syndromes, and breast cancer. New code 81348. SRSF2 is a gene encoding critical spliceosomal proteins. These proteins selectively cut out irrelevant or incorrect material from pre-mRNA. SRSF2 mutations appear to play an important role in chronic myelomonocytic leukemia. These are the last 5 new molecular path codes, which are also gene analysis studies. Codes 81351, 2, and 3 are for genetic analysis of tumor protein 53, also known as the guardian of the genome. This protein binds directly to DNA and acts as a tumor suppressor. It plays a factor in assessing DNA damage and the subsequent decision whether to initiate repair or activate cell death. It keeps cells from growing or dividing inappropriately. 81351 is for a test of the full gene sequence, and the other 2 for more selective testing. New code 81357 is an analysis of common variants in a gene that codes for U2 small nuclear RNA auxiliary factor 1, which is found in myelodysplastic syndromes that can progress to acute myeloid leukemia. 81360. The ZRS-R2 gene encodes an essential splicing factor, which is required for pre-mRNA splicing and may play a role in network interactions during spliceosomal assembly. Next slide, please. This is the first of 2 slides on new path codes related to multi-analyte assays. There is one new epilepsy genomic sequence analysis panel code, 81419. And in the assays with algorithmic analyses section, there are 5 new codes total. The first 2 are shown here. For code 81513, the algorithm here reports either positive or negative result for bacterial vaginosis. And for code 81514, the algorithm reports either positive or negative for high likelihood of bacterial vaginosis. The other three codes are on the next slide. The first two are oncologic studies, and the third studies pulmonary disease. 81529 studies cutaneous melanoma and reports risk of recurrence, including nodal metastasis. 81546 studies thyroid cancer from an FNA specimen and provides a categorical result. 81554 analyzes idiopathic pulmonary fibrosis from transbronchial biopsies, and it also provides a categorical result. There are two new CPT codes added to the chemistry section for 2021. 82077 is for reporting ethyl alcohol from any specimen except urine or breath for studies involving immunoassay and enzymatic approaches. Regarding the second code, the pre-existing code 82670, which previously held the description of estradiol, is revised in 2021 so that its established code description will in 2021 be estradiol total. So code 82670 will be for estradiol total, and this new code will follow as 82681, estradiol free. There have been many new COVID-19 related CPT added in microbiology section mid-2020. I'm only showing here those that have been added since this past October. AMA added CPT code 87428 on November 10th, effective immediately in the emergency period, to fill a need for reporting this single test that measures both SARS-2 as well as influenza A and B using immunoassay technique. The three new SARS-2 related infectious agent detection codes 87636 and 7 and 87811 were all effective on October 6th. The COVID CPT code 87635, not listed here, was added last April for use in detecting SARS-2 as the sole pathogen by amplified probe technique. These new codes 87636 and 87637 are for reporting multiplex amplified probe technique. So report 87636 once when simultaneously testing for SARS-2 and influenzas A and B, and report 87637 once when simultaneously testing SARS-2, influenzas A, B, and RSV. 87811 is used to report the SARS-2 antigen detection immunoassay that is performed using direct visual observation. Note that due to timing, none of these four new codes made it into the 2021 CPT book, but they are all valid late 2020 and in 2021. You should see them in print in the 2022 CPT book. For more details, search AMA website for CPT Assistant Special Edition October and November updates. There have been a fair number of 2021 CPT changes in the medicine section of CPT. In the next 7 slides, I will touch upon the new codes of this section. Human rabies immunoglobulin, along with vaccination, is the 2-part treatment for rabies exposure. This new code, 90377, will follow in sequence after 2 other established human rabies immunoglobulin CPT codes 90375 and 90376. 90375 is for standard rabies immunoglobulin, and 90376 is for heat-treated rabies immunoglobulin. In January 2021, CPT code 90377 will be available for use in reporting rabies immunoglobulin that is not only heat-treated, but also solvent detergent-treated. These codes are for using human immunoglobulin, IgG, purified from plasma of donors who have been vaccinated against the rabies virus. You get increased purity as you go from 90375 to 6 to 7. With the solvent detergent treated preparation 90377, there is a decreased chance of a severe hypersensitivity reaction, as well as a decreased chance of contracting an infectious viral agent from a source donor. Due to emergent nature of the release of these 6 new COVID-19 vaccine codes, they did not make it into this year's CPT book either. To report the COVID-19 vaccine toxoid manufactured by either Pfizer or Moderna, use 91300 or 91301 respectively. And to report the administration of either the first or the second dose, report 0001A, 0002A, 0011A, or 0012A. The admin codes are specific to the toxoid administered and also specific to the dose that was given to the patient. These A codes include any counseling provided to the patient related to the vaccine. The effective dates of these codes correspond to the date of FDA emergency use authorization of these 2 new SARS-2 vaccines. The Pfizer vaccine EUA date was 12/11. So the 3 codes on the top half of this slide are effective on this date. Moderna vaccine may be approved this Friday, 12/18, but we await the official approval date. Any further COVID-19 vaccines approved by the FDA in the emergency period will likely spur future releases of new specific toxoid and admin codes in a similar format to these. Although we don't have a lot of payment info for the new 2021 CPT codes, we do know that CMS will allow approximately $17 for administering the first dose of both of these new vaccines, and about $28 for administering the second dose. We will have to wait for CMS to update the payment amounts for the 2 toxoid codes 91300 and 91301, however. So back to the medicine section. This new code, along with the revision of established codes 92227 and 92228, will now provide more definitive code options to report remote or automated analysis of imaging of retina for detection or monitoring of disease. Established code 92227 is for when this is done by remote clinical staff, and 92228 is for when this is done by remote physician or qualified healthcare professional. And this new code, 92229, is for point-of-care automated analysis and report. The edit theme for code 92229 is that it should not be reported along with these codes, 92113 and 4, which is for scanning, computerized ophthalmic diagnostic imaging of optic nerve and retina respectively, as well as 92250, the code for fundus photography. These 3 new vestibular function test codes, 92517, 18, and 19, should not be reported with another code in the same code group, nor with CPT 92270, the code for electrooculography. And on the bottom of this slide, there are also 4 new auditory function tests, codes 92650 through 53. If 92652 is reported, this includes 92651. In 2020, this group of cardiovascular monitoring services are reported with Category 3 codes, but this Category 3 code series 0295T through 0298T will be deleted for 2021. 93241 and 93245 are for billing the entire monitoring service, whether 2 to 7 days in duration for 93241 or for 7 to 15 days, code 93245. The other codes here allow separate billing when only a component of the monitoring service was provided. Excuse me. Code 94619 will, in 2021, allow reporting of an exercise test for bronchospasm when done without an EKG recording. Established code 94617 already exists for use in reporting this test along with an EKG. So now just this one slide, I'd like to talk about revised CPT codes, some highlights for the 2021 codes. First off, there are 17 E&M code descriptions revised. We already mentioned changes to office and outpatient code descriptions and new add-on codes for prolonged service time and new CCMS add-on code. Also, there are 15 revisions in breast reconstruction codes, which involve mainly replacing the word mammary with the word breast. Excuse me. 2 shoulder debridement code descriptions were revised to clarify the definition of what constitutes a limited and an extensive debridement. And finally, there are many minor revisions in the 644XX series of codes, which are mostly plurals and punctuations. Okay, now I would like to switch gears and talk about the deleted codes for 2021, starting with the E&M CPT Code 99201. To better visualize why 99201 has been deleted for 2021, I'd like to first show you on this slide the 2 2020 descriptions for 99201 on the left and 99202 on the right. Previously, both required straightforward medical decision-making. The main differences between the 2 codes was in the history and physical exam components. So when in 2021, CPT removed history and exam as key components of this code group, 99201 was deemed redundant, and so it has been deleted. On the next slide, I will present the revised description of 99202 for 2021. First, you see that a medically appropriate history and/or exam is still required, but these 2 elements are no longer key components for code selection. Second, by the context of the description, either straightforward medical decision-making or total time of 15 to 29 minutes will support this code in 2021. Okay, starting at the top of the surgical section, I just want to list on the next 2 slides the 2021 deleted surgical CPTs. And amongst this first list, I already mentioned that 32405 will be deleted when I discuss new code 32408 for core needle biopsy, lung, or mediastinum with guidance. And in the second slide, the first 4 codes here have been deleted from the neuro section, and the 5th code, 69605, has been deleted from the auditory system section. These 2 radiology codes are deleted for 2021 without replacement codes. 76970, follow-up ultrasound without specification of site, and 78135, which was used in 2020 to report differential organ and tissue kinetics during a red cell survival study.
Jump past one. There.
Yeah. Thyroid malignancy gene expression analysis of FNA, current code 81545 is being deleted. And then towards the bottom of this slide, 87450 has been deleted because it was rarely used. AMA deleted this on October 6, 2020, which was after CPT 2021 books were printed, so it still appears in the book. A parenthetical note in the AMA posted changes redirects us to consider 2 other code intervals, 87301 through 87451, or 87802 through 87899. As the AMA added a series of new SARS-2 codes to this section mid-year, they revised this entire section from 873XX to 878XX in order to clarify and correlate 3 concepts across the entire section. Number 1, immunofluorescent technique. Number 2, direct optical observation. And number 3, single-step versus multiple-step techniques. For details, see CPT Assistant, Volume 30, Special Edition COVID-19 October Update. These two code deletions go hand in hand with 4 of the new CPT codes added to this medicine section for 2021, which we previously discussed on slide 34. These new codes that relate here are 92650 through 92653. Transcatheter atrial septostomy procedures 92992 and 92993 are being deleted from the medical section, from the medicine section. For reporting transcatheter atrial septostomy TAS services, consider new code 33741 that has been added to the 2021 cardiovascular surgery section of CPT. We previously discussed this new code on slide 16. These 5 pulmonary diagnostic testing and therapy CPT codes are deleted this coming January. Okay, now we're going to switch gears and talk about new HCPCS. Regarding many of the new quarter 1 HCPCS codes that have just been released on December 4th, all we really know at this point about many are the new codes and their descriptions. I've listed here the HCPCS disclaimer, which is the one that accompanies each new release. We will only get the full picture of these codes as we see policy info released at the end of this year and into 2021. Still, I'd like to expose you to the Q1 HCPCS codes and their descriptions so you can look out for new info for those that might apply to you. I will first go over 6 HCPCS codes in some detail, and then I will finish by listing the rest of the new HCPCS codes with their descriptions in alpha order. Of the new HCPCS released on December 4th, I'd like to first discuss this new G code G2212. It is one of 2 new add-on G codes for use with office outpatient EM codes. Here I show you its short description, and underneath is a caption from the CMS Newsroom fact sheet of December 1st, which clarifies that CMS created this code to adjust the time element of their prolonged service time add-on code. So we should be using G2212 instead of CPT 99417 for Medicare cases. Here is the long description of HCPCS code G2212. It starts essentially identical to CPT's version 99417 from slide 9. It too should only be used on level 5 office outpatient E&M codes, and only when time is the basis of code selection. But then at the end of this description, it reveals a significant difference as relates to the initiation time of this HCPCS prolonged service code. Do not report for any time unit less than 15 minutes. From the yellow phrase on this slide, we can only apply this code after 15 minutes of prolonged service time occurs beyond the time limit of a level 5 office outpatient E&M parent code 99205 or 99215. I will illustrate that on the next slide. When I put up slide 10, depicting time intervals for new CPT 99417, I showed there that we could start applying that CPT prolonged service time code with the very next minute after maximum total time of 99205 and 99215. With 99205 for CPT, that was at minute 75. With 99215 for CPT, that was at minute 55. This slide shows we can only apply this HCPCS code G2212 after 15 minutes prolonged time occurs beyond the time limit of the level 5 office outpatient EM parent code. So the first unit of G2212 can only be applied with a new Medicare patient at minute 89. And that first unit of G2212 can only be applied with an established Medicare patient at minute 69, as you see highlighted here. So going back to our earlier example from slide 10, and using the same primary procedure, 99215, we know this code's assigned time interval is 40 to 54 minutes. CMS prolonged time here only applies at minute 69. So only once a provider spends 69 minutes on that Medicare established patient can you build 99215 plus 1 unit HCPCS G2212. And only upon that 84th minute can you bill 99215 plus 2 units G2212 in 2021? From basic concepts from this code description, not only will the coder need to decide whether to use CPT versus HCPCS code here based on payer, but the coder will also need 2 separate tables in order to get their add-on timing correct. I anticipate significant coding errors here, especially early on. Although such errors are not fraud per se, they can contribute to waste and misallocation of healthcare resources. There is a second new HCPCS EM add-on code, G2211, for use to report increased visit complexity, shown on this slide. There remains a fair amount of confusion as to the appropriate use of this code. From the long description, we may decipher 2 significant points. First, from the underlined portions, it is for reporting complexity of encounters that are either the continuing focal point of all needed healthcare or part of ongoing care related to a patient's single serious condition or a complex condition. And second, from the yellow caption, this code can potentially be used with any of the 2021 revised office outpatient E&M codes, 99202 through 99215. Regarding this new HCPCS code G2211, I here include a related caption from CMS Transmittal 10505, released December 4th. From this CMS transmittal, reporting in this code will not be restricted based on specialty. It intends to reflect the time, intensity, and practice expense associated with providing services that result in care that is personalized to the patient. From this transmittal, as well as from comments from their MLN call from last Thursday the 10th, CMS expects utilization of this code to approach 90% for providers who predominantly report services using these office outpatient EM codes 99202 through 99215. We will be watching for more detailed guidance from CMS prior to January 1st regarding what is required to support reporting code G2211. 2 new monoclonal antibody HCPCS codes for COVID-19 were added on November 9th, 2020. The date the FDA issued an emergency use authorization of this unapproved product, bamlanivimab. The EUA allows for the treatment of mild to moderate COVID-19 disease in adults and pediatric patients 12 years of age and older, weighing at least 40 kilograms, with positive results of direct SARS-2 COVID testing, and who are at high risk of progressing to severe COVID-19 and/or hospitalization. Q0239 is for injection of this Eli Lilly product, and M0239 is for IV infusion of it. The EUA only approves its use in settings where providers can immediately treat a severe infusion reaction and activate EMS if needed. Bamlanivimab is not authorized for use in patients who are hospitalized due to COVID-19, or who require oxygen therapy due to COVID-19, or those that are on chronic oxygen therapy due to an unrelated comorbidity that require an increase in baseline oxygen flow rate due to COVID-19. These limitations have been set because benefit of treatment with bamlanivimab has not been observed in these patients. We don't yet know what payment CMS will allow for bamlanivimab injection, but we do know that when it's infused, CMS will allow approximately $309. 2 more monoclonal antibody HCPCS codes for COVID-19 were added November 21st, 2020, the date the FDA issued an EUA of this unapproved product, casirivimab and imdevimab. The details are very similar to those we discussed with the other monoclonal antibody, bamlanivimab. There is 1 dose for all patients, but here each patient gets 1,200 milligrams of casirivimab plus 1,200 milligrams of imdevimab administered together. Similarly, all patients that qualify for it will get the same dosage regardless of age, size, comorbidities, etc. So we should not see multiple doses of this code reported on a given date of service. Similarly, these drugs should not be used to treat inpatients, but instead, during the PHE, they are only approved to treat mild to moderate COVID-19 in adults and pediatric patients 12 years of age or older, weighing at least 40 kilograms with positive test results, who are at high risk of progressing to severe disease. Similarly, CMS national average payment rate for infusion of casirivimab plus imdevimab is also set at about $310, and the injection rate for these two drugs given together is also pending. I see three potential FWA angles to consider for these COVID-19 monoclonal antibody therapies. Number one, aside from patients assigned in clinical trials, enrolled in clinical trials, neither Q0239 nor MO239, nor Q0243 nor MO243 should be used to treat inpatients. These monoclonal antibody therapies should not be seen simultaneous with COVID-19 related oxygen therapy. And number three is a general HCPCS point about units. If a code's description mentions a specific dosage, the coder must divide dosage administered by the milligram amount listed in the code description to arrive at proper units. There's only one recommended dose for bamlanivimab, it's 700 milligrams. And for casirivimab plus imdevimab, it's 2,400 milligrams total, whether injected or whether infused over an hour, independent of age, weight, route. So consider reviewing medical records when any of these four HCPCS codes are submitted with multiple units. This is my last detailed HCPCS slide. With the last 9 slides, it is my intent to expose you to the rest of the HCPCS codes in alpha format. There is one new A code, A9591, which has been added to the section of supplies for radiology procedures, radiopharmaceuticals. C codes are used for Medicare Ambulatory Surgical Centers, ASC, and Hospital Outpatient Prospective Payment System, OPPS. They may be recognized on claims from other payers and in other payment systems as well. These are the 15 new C codes that have been released for Q1. This is the first of 4 slides of the new HCPCS G codes, just some of the 50 new G codes in all. Remember that as we previously discussed add-on codes G2211 and G2212 in some detail, I left them out of here. The first 3 here are reactivated codes, G0088, 89, and 90. This is page 2 of the new G codes, many of which by context seem to be for reporting quality care. This is G code slide 3. And these are the last of the new Q1 HCPCS G codes. These are the 9 new HCPCS J codes. The first 3 are drugs other than chemotherapy, J7212 being a clotting factor. And the last 6 are chemo drugs. These are the new M codes in the Other Medical Services section. There is 1 new HCPCS Q code, 1 new S code, and finally 1 new U code. Q5122 goes in the temporary codes assigned by CMS section for biosimilar drugs. S0013 goes into the temporary codes established by private payers in the section reserved for non-Medicare drugs. Esketamine is a potent ketamine drug approved by the FDA for use on treatment-resistant depression. And our last code, U0005, is an add-on SARS code to be used along with either code U0003 or U0004 in this new HCPCS U section established earlier this year. These were added this past spring to report high-throughput SARS-2 detection lab tests. This add-on code is for use starting in January by the lab that can document on average that they turn around these test results within 2 calendar days. It will be required in order for labs to continue to receive maximal CMS $100 payment per test by these services in 2021. And on this last slide, I've included my email. If you haven't submitted a question and you have one, please submit it now. If you don't want to do that, or if you have any sort of feedback for me or any question for me, please write my email down and please send it on. steve.nesnidal@context4.com. So thank you for making it through my entire webinar on 2021 code changes. Next, we'll take some questions.
Okay, thanks, Steve. Got a couple of questions here, so let me start you off here. That you mentioned that code 99201 is being deleted for 2021. So does that mean a new patient office visit of less than 15 minutes of total time should not be reported?
Good question. The answer I have, you may still be able to report a new patient office visit of less than 15 minutes with code 99202, but that depends. It depends on the medical decision-making involved in and documented with that specific encounter. Remember that elemental change in the EM code section in 2021 I mentioned. You can either base your code selection on total time or on the medical decision-making. Even though the total time documented may be less than 15 minutes, if by referring to that medical decision-making table that's in the front of the 2021 EM section, if the medical record documentation can defend straightforward medical decision-making, you can still bill 99202. Not all encounters less than 15 minutes will satisfy straightforward MDM. So for those that do not, no, don't report the new patient office outpatient EM visit code. But yes, report those that, based on your documented medical decision-making, that you can defend.
Okay. Another question was, can you give an example scenario where it might be appropriate to bill multiple therapeutic drug assay codes on the same data service, and then another example where it would be inappropriate to do that?
Sure. For my example, I can use the therapeutic drug assay of carbamazepine, 1011 epoxide, which I showed on slide 21 was code 80161. I can consider a clinical scenario for billing multiple units of 80161 on the same data service. One of an inpatient overdose treatment. Toddler came through EMS with dad, who found the child unarousable at home. Child got into dad's anti-seizure meds. They transported him to the ER, intubated him, put an NG tube in him, lavaged him, got a bunch of pills out, threw some activated charcoal down the tube. Then the child was sent to PICU, still intubated after 3 sets of therapeutic carbamazepine levels were drawn, and showed that the CBZ epoxide level was quite high but decreasing. So in this scenario, I could easily see supporting 80161, 6 units on one data service. But here, the place of service for this claim should be ER and then inpatient hospital, this patient being in the PICU likely. What would be an inappropriate example? I cannot see an inappropriate medical record supporting 6 units of this same code on one data service from a clinic place of service. I can't imagine a clinic medical record that would provide any support for this number of service units on this data service. This type of a therapeutic drug lab, maybe a neurologist would order one, along with his routine monitoring labs. I can't see 6 of these units being billed on one day. So if I'm looking through the data and I'm looking for fraud patterns, I'd perhaps isolate on the same data service, when do I see 3 or more 80161s billed on the same patient same date of service. I then check that place of service. And if it was hospital, inpatient, or ER, I just maybe take a look at the ICD-10 code, maybe looking for an overdose code and move on. But then if I looked for 80161 3 or more times from a clinic place of service, and if I could connect that with a specific provider's NPI, then I would be confident in the decision to initiate a medical record review, to delve into the details. And I think I'd be confident that I'd find a high likelihood of a fraud case or multiple. So those are 2 examples. And as a reminder, you also need to watch out for fraudulent unlisted billing code 80299, as well as I said in my previous slide, the specific therapeutic drug assay codes.
Okay. So a couple of other questions. We had one question come in about needing to find global costs for skilled nursing facility, if we had any update on that. I'm not sure that we've seen anything coming through from Medicare about what they're going to be changing on skilled nursing facility. I don't think we've seen the respective payment system updates yet. I'm going to ask that the lady Kathleen who asked this question, would you please send a follow-up email to Dr. Steve at his email address here, and then let us follow up with you in person. Perhaps we'll give you a call and make sure we're understanding the question specifically and be able to get you an answer. So we'll look forward to talking on that. There was also a request to show slides 31 and 32 once more, if possible, and we have a little bit of time. So I'm going to do that, and then Dr. Steve, if you want to address those 2 slides again, that would be great. All right, so don't get dizzy. I'm going to be paging up, so try not to get motion sickness as we page up here. But slide, we're here at 31, which is the COVID codes. So why don't you want to address that again?
Right. So they're giving the Pfizer vaccine as we speak to some people in hospitals around the country. So the toxoid, the vial from Pfizer, should be billed with 91300. And then you're going to have a pair of codes. You're going to have a second code, and that second code is for the work and effort of administering the vaccine. So these are all going to be first dose immunizations. So it's going to be 91300 and 0001A. Now, a given provider is only going to be billing both if they paid for the toxoid. But the majority of the time, for the first few weeks here, we're going to see 91300 and 0001A. And then perhaps in 2 weeks' time, when Moderna comes out, we're going to be seeing 91301 and 0011A. And then there's going to be a 3-week period, 3 to 4 week period, where these patients will have to come back to get their second dose of the same vaccine. So then, if it's Pfizer, we're going to see 91300 and 0002A. And if it's the Moderna second dose, we're going to see 91301 and 0012A. I hope that.
And then if we go to slide 32.
Right. I mean, the only thing here is that I think there's some discussion going on in terms of what Medicare is going to actually be paying Pfizer for the vial, for the toxoid, 91300. So they've got it listed here as a penny, but at some point there's going to be a payment allowance for the Pfizer toxoid. But we know that the administration cost, there's going to be some geographic adjustment. It's going to be about $17 for that first dose administered, and then $28 and change for that administrative cost of the second dose.
Okay. Oh, somebody asked if we can go back to 31. So just one more time here. I think we've kind of gone over this one, but here, Dr. Steve, you're saying the 91300 is really going to be the billing of for the serum itself.
Exactly.
And then the two add-on codes are for the actual work of the provider to administer the drug.
Right. So if you look at one patient over time who's gotten the Pfizer 2 doses, you're going to see 91300 0001A on day 1, and then 3-4 weeks later, when they come back for their second dose, you're going to see 91300 because they're going to get another vial, and then they're going to get 0002A with that second visit, which is the $28 or so, whatever that was, for the administration cost of the second dose.
The Pfizer website has quite a bit of information on it. I haven't looked at Moderna, but the Pfizer website has quite a bit of information on there. They're prepared to ship between 20 and 30 million doses, I think, within the next week, from a couple of different shipping avenues. There's instructions for providers on how to handle it, all of that stuff. So, okay. Hopefully that took care of that aspect. That was, I know that's an important piece. Another question. I noticed the E&M codes at the beginning didn't have face-to-face in the description. Would you agree that this further opens up the option to use codes such as 99201 with telehealth modifiers such as 95? Now, I don't think we can do that because 99201 is going to be deleted. Right?
99201 is going to be deleted, right? I mean, the whole concept of time with use of these codes was just kind of an estimate back in 2020. But because now time can be used to support these codes directly, now you're starting to see time mentioned in the description. But the reason why they're not saying face-to-face time, if you look back on page 8 of the new CPT book, they talk about total time on the date of the encounter that relates to these codes, office or other outpatient services. They're now going to allow not only face-to-face time, but some non-face-to-face time to count into that total time reported. In fact, they have 9 bullet points that they list as examples of non-face-to-face time that can now be counted as total time for these codes. And I'm just going to list a few of them. Preparing to see the patient, for example, review of tests, ordering medications, tests, or procedures, documenting clinical information in the electronic or other health record. So total time here includes face-to-face time and some elements of non-face-to-face time if they weren't already billed through a different code. Now, regarding telehealth and the use of these codes, we'll have to watch out how CMS alters its requirements regarding telehealth as it relates to these codes. And this is one of the areas where I want to see a little more information from.
So because these codes still would be used though in a telehealth setting, would they not, with the modifier?
Right, I think so. And I think you can make a case face-to-face and non-face-to-face time, the same kind of elements could be added up to tally total time, and these could still be used in a telehealth with a 95 modifier.
So based on what we know today, we would our payment integrity system would not fire any issues around the use of 99202 to 99215 with the telehealth modifier.
No.
Right. So
no, it's on the list of those codes that Medicare allows for telehealth in the emergency use period.
Okay.
Which is going to switch. They're going to remove some of that once the emergency period ends. And they will retain some of those procedures as telehealth eligible.
Right. And then that's CMS. But what private healthcare wants to do is really,
Right.
Private health insurance wants to do is really up to them. And I would expect the private insurance has been a lot more liberal relative to telehealth.
Right. A lot more liberal, and like you said, some of it's very payer specific.
Yep. So that actually are all the questions that we have. So we're going to go ahead and give you 10 minutes of your life back. As I said, you do know sorry, don't get dizzy. I'm going to page down to the end page here again. If you've got if you have any questions, please send them on to Dr. Steve, and he'll field those, and we can go from there. We will be posting the recording of this up on our website probably within the next week. So we'll send emails around when that's available. So in the meantime, thanks very much. Appreciate you taking the time, and you have a great rest of your afternoon.
Yeah, thanks.